Good morning, good afternoon, good evening, and a very warm welcome to colleagues from around the world to this perinatal mental health measurement webinar, which is the second in our series from the Perinatal Mental Health Community of Practice, auspiced by Momentum, the global partnership for health and resilience. My name is Jane Fisher. I'm delighted to have the opportunity to moderate this conversation. I work at Monash University in Melbourne, Australia, and I'll be pleased to introduce you to our experts in a minute or so. I wanted to, could we have the next slide, please, talk to you about the Perinatal Mental Health Community of Practice, which you are each very welcome to join. The community of practice is a gathering of people from all parts of the world with a shared interest in improving our understanding of and care for women and their families who are experiencing mental health problems during pregnancy or after giving birth. And if you look at the QR code and scan the QR code, we will show it to you again later in the webinar. It's very easy to join and we would welcome your participation. Next slide, please. And the next one. So what we're hoping you will learn from this webinar is how to understand some of the common challenges that are related to screening for perinatal mental health problems in different contexts, and that there is no one perfect way to address this. So we're going to use a conversational approach in which two highly experienced practitioners and academics in this field will respond to illustrative examples with suggestions of how they have done this and how others might consider doing it. We want to emphasize that some of the things that are very important to consider in making sure that any tool or instrument that's used to screen for common perinatal mental disorders is adapted for the context in which you are working and the women for whom you are providing care. And then we were very keen to learn from the insights and experiences of our participants tonight, and there will be an opportunity to respond to questions. We encourage you to post them during the webinar in the Q&A section, and we will get a chance to address those at the end of our gathering. But let's get started. Next slide, please. So during our April webinar, we focused on why is it important to integrate screening for common perinatal mental disorders into routine maternity care, antenatal care, intrapartum care, and postpartum care. And we heard from experts from Dr. Honigman in South Africa and Professor Chandra in Bengaluru in India about the ways they've developed to identify women's experiences of mental health problems, what locally specific symptoms might be, the importance that any questions that are asked are done in a culturally validated way, sensitive to local language and local idioms, and that have been validated to be sensitive to detect these problems in an accurate way. And there is a recording of this if you wish to catch up with it on YouTube. But what we want to move to today is working out how to do this. What are the best ways? What are some of the principles and guiding practices to think for doing this in your own context? The next slide, please. So what we're using today has been informed by challenges that have been posed to us in questions that have been sent to the community of practice about the things people have experienced when they're adapting, developing, and using screening tools. So what we want through the workshop is to learn a bit through doing how others have experienced and managed this. But I want to introduce our two generous expert speakers. So the first speaker I want to introduce is my co-chair of the Evidence and Impact Technical Working Group who are hosting this workshop, Professor Genesis Chorway. Professor Chorway is the Professor in Mental Health and Executive Dean of the School of Nursing at the Kanuzi University of Health Sciences in Malawi. So welcome to Professor Chorway. Our second speaker, Siham Sikandar. Dr. Sikandar has a joint appointment in Liverpool at the University of Liverpool, where he's a senior research fellow in global mental health. And he also is an academic in Pakistan, an adjunct professor at the Health Services Academy in Islamabad, Pakistan. They've both had very wide experience in the topic that we're going to be talking about tonight, including not only in their home countries in Malawi and Pakistan, but also in other countries in South Asia and in Africa. To the next slide, please. So we want first to draw out an example that might help you imagine a situation that you could be in. Try to put yourself in the situation of a subnational level manager of a health service who wants to introduce screening tools into the health system. But over the last 10 years, which is the period of time in which awareness of the importance of this problem has grown, many different tools have been provided. They're often ones developed in high-income settings and in English. And although they might have been literally translated, they haven't necessarily been adapted in culturally sensitive ways. Just introducing another assessment protocol, including a questionnaire, can really add to the burden of people who are already busy. And we know that this might be a task that comes to be regarded as discretionary rather than essential. And what they often tell us is that in practice, these tools are not sensitive to the experiences of women in their care, that they often lack any cultural nuance of people's needs. And the situation we want you to think about is that this health manager and colleagues in the management team want to do things differently. They want to make sure that they develop something that is sensitive to and addresses the mental health needs of women in their service, seeking care in their service, and that the terms and concepts they use are meaningful to women. But we know that these are rarely activities that are well resourced, if resourced at all. And there are others in the community who are interested in participating, community groups, women's groups in the community. We know there are no researchers available to them to assist. And this group of committed providers want to do something about this problem. To the next slide. So the challenge that we face is how do we make sure that screening tools or screening instruments are sensitive but are acceptable and are seen as useful and relevant by women who are pregnant or other family members who are partners in pregnancy or families where there's recently been a baby born. So I wondered if I could direct the first question to you, Genesis. How were patient perspectives incorporated into the development and refinement of the screening tools that you have developed and work with?
Thank you, Professor Jan Fisher, for that question. Indeed, the perspectives of pregnant women and their families are very important when you consider screening for common mental disorders during pregnancy or during perinatal period. So before you introduce the screening, there is a need to have some sort of information giving, which can be done individually or in form of groups. So in our context, if we take the scenario of an antenatal clinic, in the antenatal clinic, there is always a healthy education session prior to the provision of service. So you use that health education session to provide information to the women who are coming for the antenatal services. So you inform them of the aspect of screening which is going to be introduced. But at a national level, it means there are processes which are supposed to be followed and get approval from the Ministry of Health. So at a clinic level, as I have said, you can start by information sharing, but at the same time, this can also go to the community through community awareness campaigns. That means you inform them of the importance of screening and what are the benefits of screening for antenatal depression or any other perinatal common mental disorders. For now, that's what I can say, Prof.
Thank you so much. And we might come back to you in a minute and ask specifically about the development of screening tools that are sensitive, culturally appropriate, acceptable for your context. But in the meantime, I wonder, Siham, what your thoughts are about this particular question, which is, how do you develop an instrument? We know that just a direct translation from English using English idiom rarely works. But can you talk to us about, in addition to the things that Genesis has told us about the enormous importance of consultation with people who will ultimately be asked these questions, can you talk to us a bit about how you go about this? How do you think a screening tool is best developed for this situation?
Thanks, Jane. And I think just to build on what Genesis was saying, I would also include an important user group, which is the team that will be administering such tools within whatever context you're working. I think they need to be on board from the outset. And I like this patient-centeredness. So this goes without saying that you need to have people with lived experience informing whatever process you undertake, be it adaptation, be it idioms of expression, for what, so it has to be more community, more public patient involvement based. Ideally, lived experience should be informing the process of adaptation. So I'll say that in addition to what Genesis was saying. In terms of you're spot on, Jane, and I think we've been struggling with this to purely translate. So for example, I saw you put up PHQ-9. So translating them into the local language at times misses out on very important idioms of expression. And I can just give you from example, in Pakistan, there's no one single word that can describe depressed mood as a symptom. So we have a string of words in the local language, which is Urdu, which describes this this expression. So we've done that, and in Pakistan as well as in Bangladesh, even in Sri Lanka and Nepal, people like to think of in terms of their somatic symptoms and their biological symptoms more often than their psychological symptoms. And when I say psychological symptoms, I'm talking about feeling low, depressed, sad, feeling this loss of interest. So they'll usually think about sleeplessness, they'll think about loss of concentration, lack of energy, right? And if you start probing them, then the hopelessness, helplessness, guilt, other things come up. Lots of times, worry, excessive worry, rumination comes up. So I'm just saying that be mindful, at least from the populations I work in, they think about somatic symptoms. And interestingly, we went to Chronic A, the colleagues the authors who developed this PHQ-9, and we presented this issue, and they said that you can turn around you can front load the somatic symptoms if that helps. It will not disturb the validity or the reliability of PHQ-9. So I'm just leaving this with the audience, that think in terms of the population that you're working, get all the relevant groups, think through the lived experience lens, and bring those groups which will be administering these tools on board from the outset. I'll take a pause there. Hope this will help.
I mean, both of these are incredibly important. You know, I think what you've described so well, Siham, is that the words people use to describe this experience are not just a single term, and they're highly specific to their particular cultural context, to the ways in which these things are expressed. From our own experience in Vietnam now, 20 more years ago, when much less was known about this, we did translate with community co-design the Edinburgh Postnatal Depression Scale, and the literal translation of the English idiom, which is things have been getting on top of me, was taken in a very practical way by people to think, are you talking about a flood or something, putting things on top of my head? And that's just one concrete example. But using a question like that absolutely had no value in this context. And so I think both these points are very important, that we need to understand the lexicon, the terms people use, offer them an alternative list of words, as Siham has said. What we might come back to is this relational aspect. And I think what you've both described is the importance of listening, of hearing people's experiences. And this might not be such a practical thing for people to be able to do. But we do know that it's not only what you offer, it is how you offer it. And this will be something that we will be wanting to explore more in future webinars of this kind. We do have one question, which is, could you please tell us a little bit more, Siham, about what front loading might mean of the PHQ-9, just so everyone understands that.
Right. So thank you very much for that. It's a very simple, it's a 9-item tool, and people who are familiar with PHQ-9, so it starts with depressed mood, then loss of interest, there's sleep, appetite, concentration, and then it builds up. So just not starting with the depressed mood and loss of interest, you start with appetite, you start with sleep, you start with concentration, you start with lethargy, loss of energy. So front load them and then talk about, say, depressed mood. Then there is this, if my memory serves me correctly, item number 9, which is the last item, is about recurrent thoughts of death, suicide, better off being dead. So that's, you keep that in the end. So start with simpler questions. That often helps people calm down, feel non-threatened, non-stigmatized. It's easier for them to talk about. And why I say this, and I'm talking and speaking from my perspective, my settings that I work with, unfortunately, mental health has been medicalized. So we in Pakistan think that there is a pill for every ill. We like to think in terms of medical approaches rather than just the social and wellness approach. So people will come up and say, oh, I'm feeling low in blood pressure, which just means that they're loss of energy. If you put a sphygmomanometer, you do their blood pressure, spot on. There's nothing wrong with their blood pressure. So because then they're taken seriously, then they're given some pills, so that's where the somatic symptoms take their precedence, and it's easier to segue your further sort of probing. So hope that answers the question, Jane. Back to you.
Very, very helpful indeed. Genesis, I'm wondering if you could comment on perhaps a slightly more practical aspect. We have a question here that's been put by one of our audience members. Health education sessions are themselves already full. People are trying to cover a lot of information in those in a maternity clinic. How would the quality of education be maintained if you're adding a screening questionnaire to that session? And could you also comment on the practicalities of doing this screening in a group rather than in a one-on-one session? What are your thoughts or observations about that?
Thank you, Jen, for this question. Indeed, the health education session are already full, but as the clinics or units, this health education has to be properly scheduled. I would share one experience which we had with group antenatal care, whereby the sessions are already prescribed in the sense that you have a booklet or a manual which indicates what topics you are covering on certain dates or visits. So you would find that you will be able to cover this mental health education in the sessions. So the bottom line is that you need to have a planned schedule of the topics you want to cover with the group of women attending antenatal clinic for the whole period they would come to the clinic. Now, with regard to screening shouldn't be done for the group. You should do it for individuals. And this screening, indeed, you would need to figure out at what specific point you are going to administer the screening instrument. So as a way of making it more practical and not interfering with the usual antenatal or postnatal services, you have to liaise with the clinic. This is the health system thing, where you identify the most appropriate point where you can administer a screening tool. So for instance, in an antenatal clinic where a woman is coming for the first time, they would have a session where they are going to do their history, and the screening questions would be part of that history. And for people or women who are coming for subsequent visits, you would find that depending on the routine in that particular clinic, you would find that they do all other things, and finally maybe the person who can administer the instrument or the screening tool, if it is interviewer administered, which is really common in countries where there is low levels of literacy. For instance, it would be a midwife. So the midwife would do the physical examination on a woman as a last thing. So that would be a point where a tool would be administered. But to allow flexibility in settings where uh, literacy levels are not issues, some of the screening tools are self-administered by design. So indeed, whilst women are waiting to be attended or to receive any other services, you can give them the tool, which they can do it on their own, and later on hand it over to the midwife or whosoever is attending to them at a certain point in time. But we can't do group screening because it has to speak to, the results should speak to an individual. Over to you, Jen.
No, that's very helpful. So I think what you've said clearly here is that it should be done within a clinical consultation, and that it can be done as an interview where some additional questions are asked, or it can be done for people with adequate literacy and perhaps adequate emotion literacy. It can be done in a self-report format. And there are worldwide different approaches to this, using things like iPads with buttons you can select, or images where people can select the one that most matches how they're feeling. I think the very important thing is there needs to be an opportunity for the person completing it to seek clarification. If they don't understand a question, it's not that they're doing it in isolation. And also that the results are fed back to them in a meaningful way. It's not like a blood test where you might have to wait weeks. If someone is telling you about these personal experiences, they need some response from a clinician that takes into account what has been disclosed to them. We have active audience participation, and I think that there are a couple of questions here which lead on to, from this, that we might be able to ask our experts at the moment. One of them is asking, how about integrating a simple screening tool such as PHQ-2 or GAD-2 into postnatal care or antenatal care, because these are services that have a high uptake. I wonder, Siham, have you had experience of doing this, of integrating a couple of questions, quite a short set of questions, into routine care?
Thanks, Jane. Yes, we've had lots of experience, and I'll share two examples, one Pakistan as well as one in Nepal. So I'll start with Pakistan, and I will bring in slightly an additional perspective, and we can hold that for discussion or at some point in time later. We're pushing for a community-initiated program for perinatal mental health. When I say community-initiated, it's outside the facilities, and context where there are community health workers like Pakistan as well as in Nepal. We're pushing to have something integrated. And I know a lot of people here will immediately say that community health workers are overstretched all the time. They're a finite resource, we know. But it's a good strategy to destigmatize mental health through community health workers. So we've done a couple of things, both in Nepal and in Pakistan, to hand them with a tool.
More about what this actually is on the ground, this community approach?
So Yeah, so community-initiated care starts with, we know, Jane, from the last almost now 25 years, that there are non-specialist delivered interventions, talking therapies, psychotherapies that have shown tremendous effectiveness given through non-specialists. Now it's a matter of scaling them up. So that's a separate question. How do you scale it up? Scale it up to fidelity and hold the quality. So that's a separate question. But having addressed that, we've still not addressed how do you accurately detect people who require such interventions. And that's where the community-initiated care comes in. We've, in Nepal and in Pakistan, we've developed a tool which is known as Community Informant Detection Tool. It's very pictorial and it's a vignette-based tool. So for example, Siham Sikandar is a person who's pregnant, usually feels lethargic most of the day, etc. So it's a vignette-based. And then DSM-4 criteria, 9 symptoms: depressed mood, loss of energy, suicidal ideation, all pictorially represented. Very culturally appropriate sketches, vignette-based, and easy to tick off symptoms. Oh, this maps up to the community health worker's household person that is she's visiting. She's the informant. She looks at, tallies those symptoms, and it's not even inquiry-based. So it's just knowing, knowledge-based. So I'm the health worker who's seeing a couple of women. I am briefed on this community informant tool. I have this vignette which maps on to these people. I just tally the symptoms and I tick off if this is a match or this is not a match to the symptoms. And I then take this person to the health facility for a very trained person or a doctor or a supervisor to do whatever confirmation needs to be done, be it PHQ-2, PHQ-4, PHQ-9, or in some cases, if there is a physician available, they can do the WHO's module of the MHCAP for depression, for anxiety. So depending on your context where you work. So you proactively detect people. It's not a screening, it's not a diagnosis, it's just merely detection, proactive detection through this community informant approach. We've done this in Pakistan. We've also tested its accuracy against a gold standard, which is DSM-4 criteria, SCID interview. Nepal is doing this. Nepal has already pushed to integrate this community informant detection approach through the Ministry of Health, and they're rolling it out through a very recently a program which they call community health volunteers, so female health community volunteers. So they're rolling this out in Nepal, whereas in Pakistan, we're slightly behind. So the Ministry of Health very recently upgraded their community health workers curriculum, and we've given them three tools. One is community informant, because this was developed here in Pakistan. We've adapted that in Pakistan for maternal depression, suicidal ideation, etc. We've also given them PHQ-4, which has been validated in Pakistan. We've also given them PHQ-2, depending on the resources. So 3 instruments we've given to the Ministry of Health. And they're now these days integrating it. So those are the 2 sort of key examples that I can give you.
Well,
I'll take a pause. If you have follow-up thoughts, happy to elaborate.
I think we've had, an enormous amount of very helpful information conveyed in response to this particular challenge of being patient sensitive, participant aware in what we're doing. So reminded of the importance of listening, is certainly at the stage of developing any instrument, ensuring that the words that are used are meaningful, locally meaningful, can be understood, and people are able to say yes or no whether they're experiencing it or even to what extent they're experiencing it. We've heard about the practicalities of other competing priorities in clinic settings, so the need for this to be made manageable, so the smallest number of questions needed to be able to detect someone with needs that are not being picked up in other ways, but who might benefit from extra assistance. We've heard about the really the risks and the inappropriateness of limiting it to direct translation from one language to another language without this local process of ensuring that things are recognisable, culturally appropriate. We've heard about the importance of the use of imagery, use of images that people might be able to recognise. Does this represent how I'm feeling? And I know we heard from Professor Chandra at our last one about the image of a glass being a quarter full, half full, or very full as being a way that people can recognise to describe their current emotional state. I think what we've also heard here is that there are ways of doing this beyond the clinic setting. There are ways of doing this in the community, especially in contexts where there are local health workers who know people well, who are trusted, and who have a sensitivity to the situations of the people in their care. And the last thing I think we've heard is that probably there is nowhere where one size, one instrument is going to fit everybody, and that there might be things that people with higher levels of literacy and familiarity with self-report can do. And in other settings, it's going to be very important that these are clinician forms of inquiry, clinician-based questions. Thank you so much. And this leads us now into our second challenge, which is how do we ensure that what we're doing is accurate and has some form of validity? So the prompt we have here is that Country X's Ministry of Health went to visit Country Y to see how they were managing the integration of perinatal mental health screening in their health system. And according to Country X, they'd adapted a screening tool and integrated this into their postnatal care women's groups, which were run by nurse midwives. The program's been running for some time, but in Country X, this has been found not to yield any big increase in referrals for additional care. And you'll remember that the reason we do screening is to identify who might benefit from additional care and make sure it's made available to them. So have referral pathways and services in place. So in this setting, staff felt that the screening tool was missing most of the people with clinically significant symptoms. So the country in this setting is interested, but they want a tool that is sensitive and accurate, and they don't really know what to do. Next slide, please. So what we want to do here is to ask our two experts, how do you ensure that the screening instrument is accurate in what it identifies, minimises false detection, so minimises labelling something as an unhealthy state when it's really part of a variation of normal, and that it is accurate to detect the kind of problem that we're interested in and concerned about. So it's accurate at detecting mental health problems. I'm wondering if this is something, Genesis, that you could comment on, perhaps with reference to your own context in Malawi and what you've done to ensure the validity and accuracy of screening instruments in your context.
Thank you very much, Jen. Indeed, diagnostic accuracy and validity of screening instruments is very important in our local context and local context everywhere. And taking into consideration that most of these screening instruments were not developed maybe in our local context, but also were not maybe specifically designed for maybe perinatal period to detect mental disorders during perinatal period, because some of the instruments are just like generic kind of the instruments. But it is important that we establish their validity to ensure accuracy. So the cultural aspect which touched on the language area on is also very important, that if most of the tools are developed in other languages, one way of making them useful and relevant is to make sure that they will be administered in a language that is easily understood and the idioms make sense in that context. So the process of translation has to be robust. And there are several methods which are considered as robust or acceptable for translating tools, and one of which being the one prescribed by the World Health Organization, whereby in simpler terms, you do forward and backward translations. But translating the tools alone, it is not adequate. If you change them from one language to the other, it's not adequate. One thing I should also mention to colleagues here, we also need to be very careful when we want to translate tools, because some of the screening tools are protected, and the developers would not just want their tools translated anyhow. So it is very important that you check whether it is acceptable that you can translate the tool into another language, or you can seek permission from the developers such that they allow you to translate the tool. So once you translate the tool into a language or a local language for your context, yeah, you still need to look at its psychometrics. So there are a number of psychometric properties which you can consider, but the basic ones would to do with the sensitivity and the specificity of the tool, but also you consider what we call the area under the curve statistic. But now for sensitivity, it's how sensitive the tool would identify those who would be considered as cases. For example, if we take depression. For specificity, it is how the tool will be able to identify known cases. So a tool should have those psychometrics. However, for any other tool, when you'd want to use them or you'd want to validate them, there is always a trade-off between sensitivity and the specificity. As the sensitivity increases, the specificity decreases, and the other way around. As the specificity increases, the sensitivity will decrease. So you would need to have a balance. So science tells us that a good tool, when you are validating them or you'd want to use them in your context, should have a balance of 70% for specificity and 70% for sensitivity. But however, taking into consideration that I've said there can always be that trade-off. And one other important factor also, these diagnostic tools would have a cutoff. And these cutoffs would change depending on how sensitive this tool is in that locality. So you do also need to find the appropriate cutoff score for that particular tool in your local context. So this is what we have done in Malawi for several tools.
Yeah.
We have self-reported questionnaire, SRQ20, which normally the cutoff is at 10 or up, but you find that in some circumstances, the optimum cutoff goes down up to 6. We have done that for Edinburgh postnatal depression scale, which we have also validated locally. And we have also some other tools like PHQ-9 and others. But what is important is to do the psychometric testing. The tools have to be validated against a gold standard. So a gold standard, which is a diagnostic assessment tool, which can be a DSM-based assessment. So
really comprehensive.
Yes, go ahead, Jen.
Yeah.
Go ahead, Jen.
I think what you've told us is absolutely technically correct, but it is obviously a technique, a process that involves considerable technical expertise and the resources to do this. And I think if people are wanting to develop an instrument from scratch, they might realize that this is in fact quite a difficult thing to do. But processes of the kind you've described are available in the literature, and I think it'd be very wise for people to read, including your work, Genesis, Siham's, other groups around the world who have done this. And what they've found is that the cutoff points to detect clinically significant symptoms vary considerably, because people have different ways of describing changes in their emotional state, and the way of asking in an instrument like the Edinburgh scale might not really allow them to describe something they've been experiencing. But that technical procedure is incredibly important, and we shouldn't be using diagnostic labels to say somebody is depressed or they're not depressed on the basis just of a screening questionnaire. This does require confirmation with a diagnostic interview from a medical or allied health or nursing specialist. And that was what was described, I think, in Pakistan, where people can be taken to a clinic if they need us. Siham, I wonder if you could talk a little bit to us about coming from questionnaires that might be 10 or 20 items, which are obviously quite burdensome for an informant, but also quite burdensome for the setting in which they're being administered, to how can we be confident that 2 questions or maybe 3 or 4 can be useful and accurate in this kind of context in a antenatal clinic or in postpartum care?
Jane, if you allow, I'll just take 30 seconds to add to what you just summarized in terms of the cutoffs and what Genesis was saying. I will encourage everybody to think in terms of the minimal clinically important difference, and that's all informed by the people themselves. So each context needs to have whatever cutoff, you're absolutely spot on. So a minimal clinically important difference. So there are now studies coming up within different contexts where PHQ-9, GAD-7, you need to do that. Find what is the minimally, the clinically important difference, which is participant, patient centered approach. So I'll just leave that thought with everybody. Now coming to your question, I'll bring an example from India. We're thinking in terms of the supply side at the moment. What will be most accurate? How do you train, hold to fidelity? I saw the chat as well. A Likert is usually not very useful, perhaps more dichotomous, yes, no is easier. So you find your sort of whatever works within your settings as much as robustly as possible. But please don't forget the demand side. There was a case study from India. There's a region where farmers commit, the suicide rate is very high. And the government, the district government became very concerned. So they furnished the facilities with all kinds of soft as well hardware. 2 years down the line, nobody was accessing those services because the community wasn't aware that such services were available within these facilities. So hence, the learning was that you work both the demand side as well as the supply side. In Bangladesh, we've recently working in slums. They're not very aware about the perinatal depression as we think of it in English. So there's a lot of awareness raising that needs to be done within the slums and where to go. So when you're thinking about detection, be it proactive or facility-based, please don't minimize the importance of raising awareness. That's also to do with with your health literacy within your populations. So think of awareness raising as well through media, non-stigmatized ways of doing it. Now, coming to your question, we are pushing, at least in Pakistan, the PHQ-4, which also has 2 items of anxiety. There's now ample and mounting evidence, Jane, that chronic anxiety is a precursor, is a predictor for depression. It's also a precursor and a risk for recurrent episodes of depression. And chronic depression gets very hard to treat. Then there needs to be other interventions done. So at least in Pakistan, we're pushing for the 4-item PHQ-9. That's the easiest. Although my personal preference still for a community-initiated care is the community informant tool, which was received quite well from the community health workers. Last but not the least, I will encourage everybody on the call to think about introducing technology-assisted platforms. Technology is the next way forwards. Pakistan is getting digitized. Our community health worker program is fast getting digitized. So you need to ensure, and there is some evidence now that you can use technology to your advantage to hold people's fidelity and their competence. So it's not just reliant on me to say certain things out. The technology-assisted platforms, the iPads, etc., can help me pose those questions. So I'll take a pause there. Over to you, Jane.
Again, such rich contributions. And I think what we have learned here is that mere translation of a questionnaire from one language to another is not sufficient. And as Genesis has outlined, actually establishing the psychometric properties for each context and each setting and cultural group requires this highly technical process. But we do know, and as Siham has told us, and as questions in the chat have told us, that brief questions can be effective, and they can be very effective in a 2-step process. that you can ask people 2 or 3 questions, and if they respond positively to these, that can be an indicator that it's worth doing a more detailed questionnaire, maybe one with 10 or more items to get a more detailed understanding. And this is the process that Simone won't, I'm afraid, have a chance to describe it to us today, but has described it, and we can also give you a link to Simone Honigman's presentation where she talks about this development of a very brief set of questions that can be asked. We've also been reminded that technology can be an absolutely crucial adjunct, that increasingly people have access to it, have access at least to smartphones where things can be completed and submitted. And this is a great enabler. Of course, it relies on adequate literacy. It requires familiarity with use of the technology, but it can be a very valuable adjunct. We've been asked about what's done in different contexts. One asked about Australia, and I think someone has asked what happens in countries like England. The guidelines in England from the NICE guidelines now recommend this 2-step process where 2 questions are asked. The Hooley questions are asked about how someone has been feeling in the past recent period. And on the basis of their response to that, a more detailed assessment with a questionnaire is recommended. And this is also the pattern in Australia, which one of the people inquired about. And I think there's also acceptance that one screening tool is not going to be sufficient for a whole country. So in our setting in Australia, where we have a large population of Indigenous First Nations people, they don't want to be asked to fill in a questionnaire. They want to be asked in a very particular way questions about how they're feeling, what's been happening. And so this is a really crucial thing to be sensitive to, is that even within one country, there is diversity of preferences, and we have to make sure that women we're seeking to serve, that their views and needs are taken into account. And we've had some great examples tonight of this. We've tried to integrate responses to your excellent questions as we've gone along. We know that many of you have asked for a list of questionnaires and perhaps some of the publications that talk about the process that Genesis has described. And so I think we can undertake to put such a set of materials together. Of course, it's growing, it gets updated, but any that are open access in the published literature, we can assemble and make available to you. And we will also put together a list of some of these other ways that people are using, as the method that Seham has described, as that becomes available in the published literature, or perhaps there are other links you can give us and to Simone, so that you can follow up. We encourage you very actively to join this community of practice. It really is a venue, a place for peer-to-peer learning, where none of us are expert in everything. All of us are expert in something, and there is a great opportunity to learn here from each other's experiences. Our next webinar is going to be on how do you do this empathically. We've heard a lot tonight about the importance of respect for individuals, of their experiences, and we know that they're much more, all of us would be much more likely to talk to a health professional about how we're feeling if we feel we're being heard and cared for with empathy. So in closing, I really want to thank very much the support provided for this initiative by the US Agency for International Development, which funds this the Momentum Country and Global Leadership, including some support for this community of practice. We've been enormously helped by the leads of this particular initiative and by the technical assistance that's been provided, including by Caroline Kinsella, Laura Fitzgerald and Shannon McNabb, and the technical expertise that they have with them. But thank you very much indeed for joining. A recording of this will be made available. And I want to thank, in closing, very much our two experts, Genesis Chouwei and Siham Sikandar, for sharing so generously their insights and deep experiences in different contexts, which have been so helpful to us. So we'll close the webinar there, and we look forward to your ongoing participation.